This lecture is on the third phase of part 10. In this specific video, we will be talking about fitness testing for older adults. While we can still assess physical fitness in older adults, there are some additional considerations we need to take into account. An older adult is defined as a person aged 65 years and over. This population has the highest rates of chronic diseases compared to any other group. These diseases include cardiovascular disease, cancer, diabetes, and arthritis. The older adult population has grown quickly since 2010 with the aging baby boomer generation, and this group will continue to grow. By 2030, it's estimated that 1 in 5 Americans will be in this 65 or older group or considered older adults. Because of this rapid growth of this older adult generation, there are concerns about the financial future of Medicare and the healthcare costs associated for this group. Also, we need to be concerned about the increased physical fitness and how that could improve overall health, especially within this population. We know that as we age, there are different impacts on our body. One of the things that occurs as we cross that threshold into older adults is we have some decreased senses. These include decreased taste, smell, vision, and hearing. All of these can have an impact on one's ability to perform the activities that they had previously done at the same level or threshold. Also, as we age, there's decreased mental abilities, such as memory, judgment, or speech. We also have decreased function of the digestive system, the urinary tract, the liver, and the kidneys, as well as decreased bone mineral content and muscle mass. As we age, we have less lean body weight compared to when we are younger. Also, older adults have decreased physical fitness, and this includes cardiorespiratory endurance, strength, flexibility, muscular endurance, reaction time, movement time, and balance. Due to all the impacts that happen as we age, there can be an impact on an older adult's response to exercise. The research has shown that older adults respond to appropriate endurance and strength very similarly to younger adults, or those younger than 65. With exercise, we see increases in VO2 max, strength gains, improved walking speed, and improved stair climbing power. While the exercise response is similar, there are some things to keep in mind. When we're looking at doing physical fitness assessments in older adults, it's important to focus on functional capacity. This is defined as the ability to perform the normal activity of daily lifting and is one of the main important components. Functional capacity is important in order for people to be able to achieve their activities of daily living and maintain the ability to live independently, as well as have a high quality of life. When we're looking at physical fitness, cardiorespiratory endurance, body composition, and musculoskeletal fitness are important, especially for older adults. However, motor fitness factors such as balance, reaction time, movement time should also be included for these older adults. Also, falls are a major health problem in this population. Can you think of reasons why falls in older adults could be such a concern? Some of the outcomes that can happen after a fall are things like fractures are more likely. Part of that is due to the higher rate of osteoporosis, which can also lead to risks of increased mortality. It's important when we're talking about older adults to focus on strengthening and balance training so that we can decrease the risk of falls and increase lean body mass. One thing that can happen after a fall or any type of injury, regardless of the population, is kinesiophobia. This is defined as the excessive, irrational, and debilitating fear of movement or physical activity, We find this in older adults after a fall, that they become more fearful that they're going to fall again. The fear of motivation is associated with feeling of vulnerability to injury in response to movement. When we're talking about older adults, we know that there are gait changes that are observed. Some of these are due to pain, others are due to decreased mobility, but what we find is these gait changes include a wider base of support, increased step width, taking shorter steps, so decreased step length, and decreased gait speed. So they walk slower with shorter steps, but their feet are farther apart. Why do we care if there are gait changes in older adults? One of the reasons is because it can put us at an increased risk for falls. We also find that those suffering from kinesiophobia have decreased dynamic balance and decreased dual task balance performance. This is important because we participate in dynamic balance with everyday tasks, such as walking or reaching. Also, dual task balances could be something like turning your head when you walk or avoiding an obstacle. So we need to be able to practice these things because decreased performance in dynamic balance and dual task balance can also increase our fall risk. This table provides us with some fitness tests that can be used for older adults. These tests have been validated and were selected to focus on delaying virility and maintaining mobility. These will be discussed more in depth in the chapter. Before we have a patient or a client complete a fitness test, we want to make sure that we're selecting appropriate tests for them to do. When we're looking at these physical fitness tests for seniors or older adults, we want to make sure that the test represents major functional fitness components. It has a test-retest reliability of at least 0.8, and it has accepted validity with support of at least 2 out of 3 types of validation. These validations are content-related. If we recall, content-related is the content tested represents the entire domain a test seeks to measure. We want to make sure that it's criterion-related, which is there's a relationship between a surrogate measure and a criterion. So we've got both concurrent and predictive, as we've discussed much earlier this semester. And then we've got construct-related. This is the highest form of validity, and it combines logical and statistical evidence of validity through gathering a variety of statistical information that, when viewed collectively, it adds evidence for the existence of the construct being measured. So basically, is it measuring what it's supposed to measure? We also want to make sure that these tests reflect usual age-related changes in physical performance and require minimum equipment and space, as well as are able to detect physical changes attributed to training or exercise. Some other criteria we want to be aware of when selecting an appropriate test is the test able to be assessed on a continuous scale across a wide range of functional abilities? So is it able to be administered to a variety of different ability levels? Is it easy to administer and score? Is it capable of being self or partner administered in the home setting? Is it safe to perform without medical clearance for the majority of older adults? Is it socially acceptable and meaningful? And is it reasonably quick to administer, taking no more than 30 to 45 minutes? An example of a test that might not be socially acceptable or meaningful would be something like skin folds, right? We don't want to put the client or older adult in a place where they don't feel comfortable removing clothing in order to be assessed. So we might need to use something else to evaluate body fat percentages. When we're looking at the data from these senior fitness tests, we want to retest reliability to exceed 0.8 for all tests for males and females. We want criterion-related validity coefficients to exceed 0.7 for 5 out of the 7 tests that are administered, and a construct validity for 7 out of the 7 tests. Some indications that senior fitness testing is appropriate would be if the patient or client is ambulatory, so they can walk, community or residing adults with no medical conditions that would be contraindicated for submaximal testing, who hadn't been advised to refrain from exercise. So we want to make sure that they don't have any contraindications for submaximal testing, and that the individual can be tested safely. Some of our patients or clients might fall into a category that require physician approval. This would be a group that have been advised by their doctors not to exceed exercise because of medical conditions. They've experienced chest pain, dizziness, or exertional angina during exercise. They've experienced congestive heart failure, or they have uncontrolled high blood pressure. If a patient or client has any of these things, we would definitely want physician approval prior to testing. The next few slides provide you the instructions and the scoring required to do some of these fitness tests for older adults. These are in your book, and you can reference them at your leisure. This chart here breaks down those previous fitness assessments by percentile and age. This chart is for females. The next slide is the same but for males. This table here are criterion referenced standards for each of the tests for both male and female. These give us our cut scores. So if they are at or above the scores listed in this table, they meet the minimum standards for maintaining physical independence in older adults. Those that score below those cut scores may need more assistance. Remember, with older adults, we want to make sure that we're selecting appropriate fitness tests, that they're medically cleared to participate in those tests, and that we're focusing on continuing to help them meet their goals. For many, that's to continue to live independently, but others, it might be to increase strength or balance, to decrease falls, and be able to continue to accomplish their activities of daily living.